We optimist by will persist in the session.
Testing, 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 testing. Yayikhona enye ingoma bonke abaphandle babizeni bonke abaphandle bangene phakathi. Eh can those that are close to the doors please remind those that are outside that we're about to start? And yeah, sitshintshe amagere manje. Makhadzi. Um sizawuqhuba. Good afternoon, ladies and gentlemen. Welcome on board to Flight 234. Our final destination, it is going to be in the next 35 minutes if you are behaving. But if we experience some turbulence, it will be in the next 2 hours. So please behave so that we can reach our destination on time. I am back and I'm still Dr. Luvuyo Paeni, the co-program director. And we are going to proceed with our program for the two activities that are now after lunch. We're going to shoot straight and request that we welcome to present Ms. Kiriboni Make, who is an optometrist, but is currently doing a work for us at WSU in the Health Research Unit. And she's been asked to present South African rural provinces strategies to improve the availability, distribution, and skills mix of health workforce. Can we please give a round of applause, and over to you, Ms. Kiriboni.
Thank you for the introduction and good afternoon, everyone. I hope I'm audible enough and everyone can see my presentation. I will
Yes, you are. You
be,
may proceed.
okay, thank you. I will be exploring strategies implemented by the South African government to address the availability, distribution, and skill needs of the health workforce in rural provinces. Fortunately, previous speakers have extensively covered most of the important aspects, so I will just be touching on some of these aspects. So as it has been highlighted, inequitable distribution of healthcare professionals is a global crisis, significantly impacting the functionality of health services worldwide. So this challenge is particularly severe in low and middle income countries, where health systems face a dual burden, that is critical staff shortages and the uneven distribution of healthcare professionals. So this situation in low and middle income countries is further aggravated by the fragmented health systems and also the high burden of diseases. And one of the most damaging effects of this weakened and undersourced health system is the difficulty in producing, that is training, recruiting, and retaining health professionals, particularly in those remote and rural areas. So even in South Africa, just like many other low and middle income countries, struggles to ensure equitable access to healthcare, particularly in those rural provinces, includes effective staffing of rural healthcare facilities that is necessary to bridge the gap in healthcare access. So basically, our rural areas are the ones mostly affected by these shortages within the health workforce. So some contributing factors to the shortage of healthcare professionals in these areas include inadequate supervision, demanding working conditions, lack of infrastructure, equipment and drugs, and also lack of appropriate accommodation and schools for children professionals. And in addition to that, poor management of structures is also a huge problem. So it has been suggested that a country's ability to recruit and retain healthcare professionals in these underserved and rural areas ultimately depends on providing a stable, rewarding, and a fulfilling personal and professional environment. So while there are some health professionals who are willing to work in these rural areas, we really need strategies to persuade more of them to do so. So in response to these challenges, the National Department of Health has implemented health strategies to persuade health professionals to commit to working in these rural areas. So these strategies include clear policies on both financial and non-financial incentives, which are able to promote the retention of these health professionals in these remote areas. So we have government initiatives that involve yes, non-financial and financial strategies. And also there are policies that have been formulated by the government that includes your Human Resource for Health Strategy 2030. And also we have the coming National Health Insurance, which Dr. Baleni covered. So when it comes to the non-financial strategies, we have the mandatory community service, which has been implemented by the government for doctors, nurses, pharmacists, and other allied health professionals. So this initiative requires healthcare professionals to serve in underserved areas for a period of 1 year after completion of their studies. And also we have another initiative which requires registration of foreign qualified health professionals. And also there is bilateral agreements with other countries as some of these non-financial strategies. So one of the key principles of the policy on recruiting foreign health professionals is that they should be deployed to serve in underserved areas of South Africa. And they will only be registered to work in public health sectors. And also to support this initiative, South Africa has those bilateral agreements with countries such as Cuba that allow the government to bring doctors from outside countries to work in these rural and underserved areas. So there is also task delegation. So with task delegation, the department has also implemented a mid-level worker program to optimize service delivery. So these initiatives allows specific tasks traditionally performed by highly skilled professionals to be reassigned with appropriate training and supervision to healthcare professionals at a different level. So as part of this approach, the roles such as of those enrolled nurses and enrolled nurses assistants were expanded. And then again, new categories of mid-level workers were also implemented, such as the introduction of clinical associates, as well as introductions of therapy and occupational therapy assistants. So we also have financial strategies. So with they include your return of service schemes. These are in the form of bursaries and policy. So this policy provides a non-pensionable fixed percentage allowance linked to the annual salary notch for most categories of healthcare professionals. So the primary objective of this policy was to attract and retain skilled professionals in rural and underserved areas. So by offering financial incentives, the policy aims to encourage health professionals to commit to full-time service in public health facilities in designated rural areas identified by those provincial health departments. So challenges that have been faced by the government is that while these strategies have been instrumental in addressing healthcare workforce challenges, it is also important to acknowledge that rural areas are still very different from urban areas. So rural communities will continue to face challenges related to education, communication, infrastructure, and transportation, which are not being experienced in urban areas. So these factors are considered to directly impact the ability to attract and retain healthcare professionals within rural areas. So as a result, these living and working conditions will remain a critical barrier to achieving equitable healthcare workforce distribution within rural areas. So it is important to address these broader socioeconomic challenges so as to achieve long-term success of rural healthcare initiatives. So as a call to action, as part of the recommendation, universities are advised to collaborate with local communities so as to provide medical students with hands-on community-based experiences. So institutions such as WSU University also deserve some recognition because they prioritize community-based training as a key component of their medical education. So this approach, community-based education, it ensures that clinical graduates gain real-world exposure to the unique healthcare challenges faced in rural and underserved areas. That is including your limited resources, high disease burden, and staff shortages. So such experiences not only enhance their adaptability and problem-solving skills, but they also prepare these graduates for them to work effectively in this environment. And research has shown that medical students who undergo community-based training in rural settings, they are more likely to return and serve in similar communities after graduation. So strengthening these initiatives, it will be a crucial it will be crucial for building a sustainable healthcare workforce that meets the needs of South Africans. Thank you. I think that is the end of my presentation. Thank you.
Thank you very much, Kiriboni. Let's give you a round of applause once more. Please stay online, Kiriboni, but we're going to have one presentation and then we'll combine the questions for both of you. Moving right along, we are now going to be inviting for a presentation, second to last for the day, our host, to say the least. He's a South African trained public health medicine physician. He did his PhD, which was focusing on improving an understanding of how African governments have designed and implemented health professional training policies aimed at improving the provision of better care to underserved populations in selected Southern African countries. He has more than 15 years of research experience in African health system. Of late, he has been researching in Southeast Asia to draw lessons on their health system to address the growing burden of non-communicable diseases. He's an experienced manager in South Africa's public health sector and has served as a member of the Mpumalanga Provincial Premier's Advisory Committee on Health. He received his Bachelor of Medicine in Surgery and Public Health Medicine (MED) degrees at the University of Cape Town, and went further to obtain his PhD from the University UNSW in Sydney. His passion in human resources for health and had his first Cochrane systemic review publication in this area in 2005. He has more than 50 peer-reviewed articles, mostly in health systems and human resources for health. He is the inaugural director for the Global Center for Human Resources for Health Intelligence at Walter Sisulu University in South Africa, and is an associate dean for strategic affairs at the same institution. May you please join me in welcoming to the fore Professor Skhumbuzo Mabunda. Thank you.
Thank you, Program Director, for the kind words. I have the graveyard shift. The good thing about the graveyard shift is that no one is listening, so you can do whatever you want to do and sing and dance. May I first acknowledge the Abatembu Nation, who are the original owners of the land on which our university and hospital are built. I also acknowledge the current and future leaders present here today. Really, today I will, my presentation is made easier by the fact that everyone has spoken. All I can just say is that kila kaleu, everyone has spoken, and I agree with everything that has been said. But I will just highlight a few points, really, six, and we'll not delve as deep, because anyway, colleagues have already covered everything. There are a few things that have not been mentioned. The challenges through scenarios. The William Peak report of 2001, I'm sure you have seen this many times. HRH policy challenges. Challenges of human resources for health in South Africa. And the question then of what value the Global Center for Human Resource for Health Intelligence will add. And scanning some current challenges. I think if there's anything to take out of here is that before you start any project, check that you've got the necessary resources. This is me at some stage, believe it or not, I was once the tallest with my three brothers. The younger one being Education, that's his name. Education, that's his name. At the age of 12, teachers started noticing that when he was in class, apparently was the cleverest in the class, but he had to sit in front of the class because he couldn't see properly. He was then taken to hospital, the nearest hospital to home in Mpumalanga, where I come from, my province. As you might see, this is a farm where we were. So when we went to the hospital, the doctor said, well, there's nothing we can do for you. There are no optometrists in the public sector. There are no specialists. What you need to do, continue sitting in front of the class. It was not until the age of 21 when he had to come stay with me, I was already a medical doctor at that stage, that he came back to me one day from uni. He says, a car almost hit me. I couldn't see the cars. I went blurry. At that stage, I recalled that he had a problem with his eyesight. I took him to the hospital where I worked. Initially, before I took him to the hospital, I took him to a private optometrist who was able to diagnose that there's a serious problem with this person. He needed to see a specialist. And I took him to the hospital where I worked in the public sector. I jumped the queue, yes, I did. He was then diagnosed with keratoconus. That needed an intervention. Generally, it needs eye lenses. And in some instances, an operation, like it did with him, because it had gone severe. So he had to have an operation. If you are to look around this country, I'm glad that an optometrist presented before me. Go around any public sector hospital and see how many optometrists you have. Actually, the question should be, how many optometrists are there within the public health sector in South Africa currently? Is it not essential care? I will go to a second story, it's also about my brother, education. On the 26th of December, the morning of the 26th of December 2015, early hours, around 3 o'clock in the morning, I was called to be told that he had been involved in a car accident. I managed to get myself there with my other younger brother, who's closest to me, also wearing a blue shirt. We got to where he was, the accident scene. The driver had died. He was still alive, but in hospital. I went to the bedside because I'm a medical doctor. I had to sit next to him. He has private medical insurance. He had private medical insurance because he was employed at that stage. Now, the public hospital where he was needed to transfer him to a private hospital. For him to be transferred, he was so severe that it required an ambulance. But unfortunately, we couldn't find an ambulance that had advanced health workers, paramedics, who would be able to transport him. As a result, we had to wait for over 4 hours. The next challenge was also that there was no neurosurgeon in the whole province, whether public or private, because it was the 26th of December. The two that were there in the whole province were on holiday at that stage. Now, that then tells us that with or without your medical insurance, when we do not have the adequate resources, sometimes it doesn't actually help to save you even. He demised later that night. Now, I'm just trying to highlight the fact that we are busy mostly talking about health professionals as if it's only limited to nurses and medical doctors, and dentists and pharmacists in some instances. But there are many cadres of health workers that are very important to us. We need to be able to decide as a country what is it that is actually necessary for us and be able to equip them appropriately. For a living, I speak to health workers across all sectors. I've been spending a lot of time with oncologists of late. I had a discussion with an oncologist as to why they had left the public health sector. And these are the reasons that the oncologist cited. There are delayed patient referrals to get to her. You can guess then that it's a female who was the oncologist. Patients take a long time to get to her. By the time they get to her, they're already advanced. There's nothing she can do. All she can do is to just look at them and really, if she prays and palliate them. At the same time, because these patients are already in late stages, so generally there's nothing that can be done. But then within her unit, there was a long waiting time as well. She was always exhausted whenever she got home. At the same time, some therapy that she feels she needs to learn and also is helpful for patients, such as immunotherapy and some targeted therapy for some types of cancer, is not there in the public health sector. So she felt that she needed to actually go to the private health sector to explore this. Sorry to bore you too much. The very last one. I've recently returned from Australia. A guy who came to my house to help install internet connection, a cable, found out that I had returned from Australia recently. His exclamation is, "Oh, so you were in Australia when they intentionally injected people with a disease in 2020. This disease was man-made, he says. It was man-made and was inoculated on individuals to lie to us that it was natural. They closed businesses and we were all suffering and people lost jobs. As we speak currently, in the city where I live called Buffalo City or East London, there is an outbreak of hand, foot, and mouth disease. Do we have the adequate and necessary public health care to handle or deal with misinformation, to manage outbreaks, or to even deal with any other condition? By the way, with any of these situations, including the oncology scenario, it could be any condition. It could be hypertension, it could be whatever else. This is exactly what it is we're experiencing from our patients. Delayed referrals and late diagnosis and long waiting times. If you are to go to any hospital, including the one where we're at now, go and see how the queues look like. Do we have an adequate supply of health professionals? You will answer that. From the peak report, I mean, many things have already been said, but I've highlighted one in green. Relate current resources and projected needs. So you need to be able to say, what is it that you need? What are the resources that are there? And how do you actually eventually get there? Unfortunately, this is where we fail mostly. We've not actually done our homework well. I'll jump this. Really, it's one of the PSEP report. Is one that looks what was funded by a private insurance company, foundation rather, Discovery, and also an independent organization to look at the projections of specialist medical professionals to 2040. And you can see by and large, there's going to be a shortage in 2040 for most of these specialists or specialties. Is the evidence for any of the policies that we have in human resources for health, be it rural allowance, be it compulsory service, we refer to it as community service, be it even commuted overtime? Another question that I know South Africans always pride themselves by saying we've got the best policies in the world, but they are poorly implemented. But is that the case? My argument generally from my research has been that we often do not actually plan well our policies. We don't develop them well. We think we develop them well. But possibly the intention of the policy is well. That's all that there is. But the reality is that the process of developing that policy, because it needs to tell you how you are going to be able to determine whether you have achieved what the policy said to actually achieve. That is the most important thing about any policy development. Then you can go to implementation and monitoring and evaluation. I will then cite an example that has been highlighted in a way by Prof. Joshua when she mentioned some of the work we did. We looked at 4 different countries in Southern Africa: Eswatini, Lesotho, Botswana, and South Africa. Eswatini and Lesotho do not have a medical school. Botswana has a medical school, with South Africa now having 10. In South Africa, we looked at all the 9 provinces. In Lesotho, we interacted with the Ministry of Labor, of Health, and the National Manpower Development Secretariat, which is responsible for training of any cadre in Lesotho. In Eswatini, the Ministry of Labor and Health. In Botswana, the Ministry of Education, equivalent to our Ministry of Higher Education in South Africa, and also the Ministry of Health. Return of service agreements, as has been highlighted, is what we would ordinarily refer to as bursaries. Health professional, aspirant health professional often is given funding in return for them going back to work for government. We'll get back to this as I say. But then one of the longest running agreements has been the South Africa-Cuba agreement, where health professionals are sent, medical professionals rather, are sent to Cuba to do medicine, and in return that they would come back and serve our country. My home province, Mpumalanga, has had its fair share, sending some to Russia as well. Part of the challenge is, as you might see from the objectives, with the Mpumalanga Russia agreement, professionals came back from Russia, and at the end of, upon their return, many could not be placed. Firstly, because they had to write a board exam from the Health Professions Council of South Africa. Something that had not been planned for in advance as to how they would actually go in and be integrated within the system. And as I highlight the different ways that we went about it, we looked at literature, we looked at the actual policies, we tried to examine and find the policy documents that founded this particular policy. We had in-depth interviews with policymakers. We looked at a cohort of every single provinces and countries, individual that would have been funded between the year 2000 and 2010. We wanted to understand. So you funded Sikhumbuzo Mabunda. On what basis did you fund Sikhumbuzo Mabunda? Or maybe before then. What actually informed the development of this particular policy? What are your views as policymakers on this particular policy? But what informed then the decision to fund Sikhumbuzo? Was it him being the top of his class or achieving good grades? Was it him being needy, needing financial assistance? Was it him being a rural environment? Was it him being identified and linked to a service area that he actually is needed in a particular service area upon completion of his studies? How then do you decide which profession you fund within the health sector? Is it based on the applicant's aspiration, or is it based on the needs of the department? How much do these schemes cost? That's very important. How much do these schemes, and I have to declare, I'm a beneficiary of that scheme. You can guess from Mpumalanga. What are the factors that are associated with retention? How much funds are recovered from those who default? Because one of the conditions is that if you do not fulfill your contract, you need to actually pay back the money. How many do indeed pay back the money? As I said earlier, all provincial departments in South Africa were interviewed, and then these are the ones in the other countries. The reasons by policymakers was that they actually are going ahead with this policy because it's continuity. They found it there, so they have to continue the legacy. Some say, well, they have to address critical skills shortages. Some say it's social responsiveness to the needs of disadvantaged groups. And disadvantaged groups would be preference for individuals from and racial groups. Some will be from low socioeconomic status. And also compliance with legislation as well. And other political reasons and agreements that governments would have reached, including the bilateral between Cuba and South Africa. The qualitative findings were that there was poor archiving. In South Africa, one of the poorest was that you couldn't find in any one province anything that tells you this is actually the reasons why this policy was documented, was actually founded, and this is when it was founded. The earliest we could track it to was 1950. But we couldn't find the actual origin. We were able to determine that with certainty in Lesotho, and we're able to determine that with certainty in Eswatini as well. In Botswana, almost with certainty around 1995 as well, because that is the newest. They were poorly coordinated between the various stakeholders and departments that actually are involved in the scheme. There was poor recovery of funds from those who were funded. And no evaluations of any of the schemes anywhere in these countries. And by the way, including in literature, you can look across and see which one has been evaluated. You won't find any. And some of these really, biggest challenge really, was the fact that lots of data was missing. If you look, those who know and are familiar with South Africa will tell you, I'm still, this is Botswana, Eswatini, and Lesotho. These are different programs and different countries where they go to, mostly biased towards medicine. So that decision again is mostly based on who applies. But I was saying about South Africa, those who are familiar with South Africa, you will realize that KZN, KwaZulu-Natal province, has the biggest scheme of all the provinces over time. But you will see between 2003 and 2005, there is no one represented there because there's no data that you could find. For many of the provinces, including Eastern Cape where we are today, they couldn't find data of anyone who was funded to study in South Africa. The only data that you could find was for some period for those who studied in Cuba, medicine. The question then is, what were you investing on? Even then on money, how much money did you pump into this program? None could actually tell you. Oh, sorry. As you look at the numbers. The little that we had on compliance, on service compliance, was that there was a high defaulter rate generally between the units that we assessed. Where you would ordinarily expect an equal duration, almost equal duration, an almost equal duration of the funding period and the service duration. Or if anything really, the service duration should be longer. But by far, people were funded for long, about 5 years, and they only gave back less than 2 years. That's more than 50% of them. And factors that are known, I mean, a person doing community service is not supposed to undertake, that's in South Africa. A person doing community service is not supposed to undertake community service in another province if they were funded by government. But we found this happening here. It is also at this point that it's important to mention a few things. Some of the individuals could not be employed by government. They completed their studies, but could not be employed. Now, that's where the unfairness comes in. Individuals sign a contract that if you default, you have to repay government because you are meant to serve government. But if government is the one who defaults, that doesn't reciprocate. It's also an opportune moment to also mention that part of the challenges that there is as well, those registered, health professionals who are registered with the Health Professions Council of South Africa cannot readily be employed by the private sector. So it's very important to also highlight that nurses are different. They're not registered with the HPSA, the Health Professions Council of South Africa. But all the others cannot readily be employed by the private sector. The only way would really be them being partners or actually opening their own, which limits their options really to mostly the public sector. That's why there's the feeling that doctors might feel entitled. And we see that in evidence as well. Is this a worthy investment, this particular scheme? What we found is that you put in $100, you get back, you lose almost $48 through defaulting. We can't actually for sure tell how much return of service schemes cost government, but it's a lot of money. And I think if you've invested that much money, you need to at least get something for it. And part of what we need to do as a unit is to really understand what is the true value of a health professional. You health economists will advise me. What value do you attach to a health professional that you have trained now? So we need to be able to get to that. And different cadres will have different values, and for us to be able to say how much investment is this worth. The South Africa-Cuba agreement is such that those who started in Cuba cost 5 times more than those who started in South Africa. And we increased those in large numbers between 2010 and 2012. 3 cohorts of 1,000 each. That also increased the so-called supply. Because we hadn't planned for that, it's then difficult to factor them in as to how they actually go into the system. Because when you give them, when the bursaries are awarded or the ROS schemes are awarded, there is no planning as to where in the health system they're going to be, how much money they're going to consume. So the question is the only problem about implementation of policies? And I will tell you, it's definitely not. It's bigger than that. And part of these challenges as well, we don't change much the skills mix of health professionals, because it's really dependent on who applies and who we find. It's not based on needs that we have as the health system. And needs, I'm referring to evidence-based needs, not needs that we look at and say what posts are vacant and what actually is required. That is not a need. That is just what is there. And there is the current process, the plans and wishes really. The plan is that, we have the shortage of health workers, and then you will wish that, you will eventually have people returning. But unfortunately, the complexities are such that there's a maze. There are many processes at play. And all of them really need to actually be examined at once. And if we summarize them in 4 phases really, say the planning, implementation, monitoring, and evaluation need to all be coordinated. And again, I'm not a Nobel Prize candidate, because many of these things have already been said before. The challenges have long been known. Smith and colleagues actually summarized this very well. There is poor human resource for health planning within the country. There is geographic maldistribution. And not just South Africa, by the way, across the board. Poor interface between the training platform and health facilities. And then in 2018, they referred to a large number of unplaced junior doctors. So where then do we see ourselves fit in? We are a global center located in South Africa, but serving the needs of low middle income countries, mostly in Africa. We want to serve the needs. Yes, charity begins at home. We would like to work with the South African government. We would like to work with any other government in Africa. We would like to work with many organizations, as I will highlight later. But then we want to cover 4 areas by and large: the availability, distribution, competence, and wellness of health workers. And as Professor Mann highlighted, part of the challenges is competence. We assume that people have been trained, therefore they've got all the skills. But actually that's where we need to go and focus more. And we're going to invest on all these areas and make sure that we've got science behind everything we do. Our capacity really will be on technical assistance, assisting with human resource for health strategies, epidemiological research, because everything will need to be based on who, where, and when actually people get affected by conditions or health needs, or deficiencies for that matter. Health system strengthening, policy analysis. And then also there's education and training, naturally because we're an academic institution, but at the same time because of focus on competence as well. Data analytics and visualizations. And we also include, as one of the many things, as we're celebrating 40 years of our existence as a university, faculty rather, of medicine and health sciences. We want to include tracking of graduates and employees, for anyone who actually requests for our assistance. Have employee dashboards, look at efficiency measures and also absenteeisms and turnovers and all that. And monitoring and evaluation. We would like to build lots of partnerships. We've already begun with many of the esteemed guests being here today. We really appreciate and are humbled by the presence of these colleagues. And we hope that will grow from there, from strength to strength, which was doing well initially, but today is really not there. Because they never moved with the times, which is what we need to be able to do in health workforce planning. We need to be able to move and adapt with the times. Come together and say, we need to be able to move and adapt with the times. Come together and say, do we need to remodel the way health workers are actually operating at the moment to better use them? Do we need to repurpose some of our health facilities, as a matter of fact? So these are discussions that we need to look at. And again, working together, we can do more. I'm not stealing anyone's slogan. Thank you. And I think it's opportune for me to also, because I'm a researcher, for a living I speak to health workers. And by the way, this was prepared way before Dr. Bayeni and Dr. Mahlati actually took to the podium. Commuted overtime is one of the biggest contentious issues that come up at dinner parties. It's important to highlight that this is based on need. It's not an entitlement, and it should never be. I previously, in my first stint at Walter Sisulu University, I would have taught medical students between 2015 and 2018. A lesson I would always tell them: do not plan your life based on variables. A variable can be taken away at any time. Rural allowance, commuted overtime, and so on are variables that can be taken at any time. Don't plan your life based on that. That's the first thing. But then, just to bring on board, because I'm aware that there's an international audience and other people online who are listening who might not be familiar with this concept of commuted overtime. Really, it's fixed overtime where generally, and it's not the same as simple as this, but then I'll simplify it and say a medical professional is paid an extra 53% of their basic salary for rendering a service after hours. It's about 80 hours per month. Again, this is the simplest version. That's the largest proportion of medical professionals. So if a person is getting paid 100 rands, I'm using South African currency, as a total cost to employer on the letter, the basic salary will be 70 rands. The commuted overtime will be 53% of that 70 rands, not of the 100 rands. So that will amount to about 87 rands. So that really is what a commuted overtime generally is, and that is a contentious issue then. Now, the impression then is that there are more health professionals or medical doctors, because it's mostly limited to medical doctors. Then we should change this, how this works. The importance is that it might well be the truth. I just recall teaching I received from the University of Cape Town when I was a medical student. One, Professor Vanessa Pesh. She said, because currently, what is noted generally is that some provinces now, as we speak, are actually projected to underspend on their human resource for health budget by the 31st of March. That's the reality. The reality is that we've got not just doctors unemployed, we've got many other cadres of health professionals Are we only considering bringing in the unemployed doctors because probably they're making the most noise? But let's look at all the other cadres. What are our needs and what it is that we can do together? Let's identify all areas of wastage. There are those, yes, who are obviously being paid for committed overtime when they do not even engage in it. Let's make sure we identify clearly those areas of waste, including even reviewing some other policies, as you mentioned earlier, Dr. Bayen. Do we still need district clinical specialist teams? Are they relevant, really? Are they evidence-based, as a matter of fact, that those particular identified specialties are the ones that we need in the health system? Renefeld and colleagues in 2020 wrote an amazing article, Schneider and Archaliman. They say really what we need to look at is, one, good governance, and that is formed by a number of facets: capable stewardship, appropriate mix of technical and administrative skills, and explicit political support. And political support is not limited to the Ministry of Health. It's across all the major departments. You mentioned Department of Higher Education and Training, you mentioned Treasury, bring on board the PSA as well, Department of Public Service Administration, the employer. All of them in one room and speak in one language and coordinate it, understanding what it is we want to achieve for our population. Then they would have moved further. As I said earlier, eliminate the waste in the health system. Academics are there to serve the people of this country. Let us be there to assist you. And as a center, we are open to that and would like to actually be part of the solution. Share all the data that is necessary. And again, as I said, areas of waste might be the major issue that we need to touch on. And it's important to employ the health professionals. Professor Mann has shown that we actually do not have enough. And as I said, we need to be able to look at the day when we're saying that patients do not have long waiting times, patients do not take long to be referred, patients like my brother get actually assisted with the needed care that they need when they need it. Then we can say we've got enough health professionals. And we make sure that this year's shortfalls or any other year behind us do not recur. I think I've said a lot. Thank you.
Thank you very much, Prof, for that resounding closing presentation. Can we give him a round of applause once more? All right. I am told that the Dean is going to make a plan, and he always keeps to his promise. For the disappointment I am expected to deliver, that we might not have time to engage with the last two presentations due to another pressing commitment that some of the presenters as well as the executive of the department is expected to engage in, which was scheduled for 16:30 with the department to solve these issues. You said we must partner with provinces as academics. Yes. So we have been requested to humbly apologize, as we might not be able to interact with the last two presentations, and sincere apologies for that. And in case I misrepresented the Dean about the promise to make it up to you, he's gonna come to the fore and explain exactly how he's gonna make it up to you, or correct me if I misrepresented him. Now we are coming to the part where we are just gonna have closing remarks from the Dean in terms of how the day has gone. And let's give him a round of applause as we welcome him to the stage. Thank you.
Good afternoon, everyone. I must really apologize. We did go a little bit beyond time. And, you know, when you are going to negotiate, you don't make the people where you want concessions to wait for too long for you. So I want to apologize for interrupting the program. But before I proceed with my difficult task, I just want us to give a good round of applause to Professor Mabunda for launching the new center at WSU. Colleagues, you know we've come a long way, and we've been having building blocks towards today, and he has been made the founding stone to make sure other blocks can stick, and he has agreed to take the responsibility and lead the way. Ours is to support him. You have heard him talking, you have felt the passion. And what I like, his last slide, the passion for solutions, and urging all of us to partner with him and his team on his journey to find solutions, not to create more problems. We have enough problems. We need a bag of solutions, and I am sure he's capable of leading us in that. So I want to thank him for taking, that responsibility. But also, before I forget, that I don't get carried away, it's important, to thank the whole audience for being here, taking time, sticking out the whole day, short breaks in between. But I think let's give each other a good round of applause for that. Because I'm going to forget the organizers of this, I understand there's a very good attendance even online. People have been sending messages to me asking for the links and all that. So the organizers who brought us together to spend today on this important area of our work, I think let's give them a good round of applause. So here at home, we appreciate the visitors first. And without wasting time, we've had a good array of presentations in various areas of the work that we will be working on, taking stock of where things are, but also getting ideas on how to take the work forward. I'm sure we have taken lessons, as the team here, on things to build on. So there are certain people I will just touch on. Professor Joshi, we treat her as one of our own. She has been with us now for some time. We have been working with the team in public health, and the work that we've been doing, coaching, mentoring, assisting with looking for funding opportunities, that work we appreciate. So today she presented on the future of the health workforce and emphasizing on the challenges and opportunities. She highlighted, I think, some key points that I think I would love to touch on here as part of our homework. Firstly, she actually opened this platform and provided a scene using the health system's building blocks and emphasized key areas in there. One of them is obviously human resources, area of leadership and governance. She emphasized the role of community health workers in promoting community health systems, and also use of digital technology as an enabler for health worker performance, not as a negative, a barrier, as an enabler for health worker performance. So we are taking that message home because of where we are. We got a presentation from Dr. Thomas where he left us with a homework on the Smart Health Program. Yes, he presented from the perspective of their experience in Indonesia. But I'm sure you all heard Dr. Mashati when touching on it, that he doesn't dispute the need for it and the need for programs of that nature, but he just was raising other issues which are local issues. I'm sure Mr. Lugege knows, the local issues on softwares. But the reality is that the programs, we will explore how far we can go with this. And I'm leaving it with the public health team to discuss and see what is it that we can do. There are lessons that we picked there. So we would love to leverage on the use of technology to balance HR constraints in the environment where we are. So that's our appreciation, Dr. Thomas, for the presentation. And Dr. Blake, covered an important part of this discussion, and I suspect it might be the foundational part of the discussion. And often you don't find it in most of the policies. You know, we have been made to believe that we've got the best constitution in the world. From whose perspective? Yeah? We are number one in terms of, you know, the, what do you call it? The, but we're number one in almost everything that is not going right. And we must blame something. And one of the foundation documents guiding our life, our Bible, is the Constitution of the Republic of South Africa. And the highest unemployment we'll find is manufactured by the best constitution in the world. And we go on to celebrate, vote in every administration, and celebrate the same people who put us deep and deep into poverty. So with the best constitution in the world, with the worst poverty you can find, highest unemployment rate you can ever find. So he says there is insufficient economic evidence guiding investment in non-traditional models of care. Nobody can dispute that. We meet, plan, change a system, no evidence has been presented. Somebody has just come and says, I want a clinic here. I have promised a clinic. So we're sitting with that problem 30 years into our democracy. When are we going to learn? He also emphasized the important point, which is true, the importance of strategic investments in health workforce. It is not expenditure. It is an investment. We cannot be compared to many sectors that exist because we are a key contributor to an inclusive economy, as Dr. Bayeno was saying. So we talk too much about expenses. Like now, somebody said in one session, now we've got an oversupply of doctors because of medical schools like Walter Sisulu University. I'm sure you heard that one. Yes. That's the mistake that we are going to feed the community. The communities, they go to the hospitals, they don't find doctors. What evidence do you need to go and say you've got an oversupply? When you can't afford to run a sponsor shop, you say now you don't need the sponsor shop. So this gentleman reminds about the strategic investment on that. But if I highlight something that I think Professor Mabunda touched on, in his presentation, shortcomings in policy leading to minimal or unclear impact. We claim something is working because it is analyzed to suit a particular narrative without really doing proper work, and you go and make that noise. Now we've got multiple HRH strategies or so-called incentives with no evidence of whether they assist or they don't assist. He also touched on an important point that says there's a need to focus on community assets, capitalize on their strengths in order to close capacity gaps. We sometimes want to import things when we've got our own strengths, but we're failing to appreciate and take advantage of them. But also a very important point for us, because we're in the battle for the mid-level workers. The system since '94 has undermined the role of mid-level workers. There is no champion for them. You are led by curatively minded leadership or managers. They think pills and tablets. They think stethoscope before they think the community. And those are our policymakers. So here he says, when properly supported and supervised, many interventions led by non-physicians or non-specialists can be cost-effective. Imali pelile ke ngoku. Bayidlile amasela, ayizobuya. We need to look at alternatives, alternative models, and the cheaper models, so that you can stretch the dollar. We need that. Iphelile amasela azanishiya xa iphelile nizosala nisilwa nama edamini. Yena uzibona ingwenya xa zifika edamini li-dry. That's what is already happening. They are chewing each other. Ours is to save ourselves. We will not be saved by politicians. We will be saving ourselves. The journey starts now. Last point, I think I've touched on it, interestingly touched on it as well. Health worker corruption has been seen as an intractable problem for many years. What are we doing about it? Yeah, I was chatting to someone earlier on that enormous, my role in my capacity as a dean, Professor Steve, is I'm a head of a WSU academic health platform. It includes facilities managed from both sides of government and university resources put together in order to be able to produce the health professionals we have. Now, what I have learned, which I have not said in public, Sukumbuzo, I'll say it for the first time today. I have never imagined in my lifetime that I could coexist with a captured hospital. Nah, I've never thought that South Africa would get to that. That is what you are faced with now. It's time to take the baton, face it head on, make proper decisions. One decision starts with being a voter. So he says health worker corruption has been seen as an intractable problem for many years. I am saying I have never thought I could coexist with a captured hospital. It's an unfortunate consequence of failure to intervene. So Professor Steve, very important point again, he gives a great input. A take home for me is that economic disadvantage as a determinant of health. Ne? Siyathanda ke uba sihambe sisithi siphuwa. Clever kakhulu, si-rich la. Lady, we need to create an environment conducive for us to deploy our resources correctly. Ne? Yes, economic disadvantage is a disadvantage. Ne? But we know we have had many barriers and we have tried to deal with them. Some we have dealt them successfully. Even the one today, we will deal with them. It's a matter of time. He touches on a very important aspect of the work which has become common today. We experience it now every day, left and right. Catastrophic costs associated with illness. We're losing jobs, whether it's COVID or something else. We travel long distances to care. We are told now our specialists must work around where they are. They can't go to where we need them. We are given all the stories. I said you are the voter. Probably it's time to go and think. He also highlights a very important aspect, of what we have become, what has been increasingly experienced or transferred to patients, out-of-pocket costs associated with access to care. For those families that have got sick people, but also for the health outcomes that we expect. Very interesting part, that I think we must note because we're sitting with also a very difficult burden of disease, with the NCD component. Take home financial protection for NCDs is generally not commercially viable. You have nowhere else to go. Ne? So your vote is very important. Remember, today we talk about the national health insurance. There are those who are for and there are those who are against. Ne? Eh? I listened to some of us, I thought we were better educated, but some of the arguments we forget that all of us are ending up there, by the way, with those NCDs. Ne? One day, you will not be insured. Ne? Where should you go? Nditi? The capacity of the state to ensure that all the vulnerable and the needy are taken care of needs to be protected at all costs. So he's reminding us that financial protection for NCDs is generally not commercially viable. So no investor wants to put the money where they're not going to make profit. So, Dr. Bayeni, you have covered everything. I appreciate it, my brother. You reminded us on the goals of the HRS strategy. You shared progress of that. You even told us that our clinical governance is generally poor and it contributes to wastage. But we know the answers. There's evidence out there of what works and what does not work. We have got a failure to take evidence to policy and practice. You see, when I studied in the early 90s and early 2000s, government of the Republic of South Africa was working very well with universities and university research centers. Today, they've diverted and created things that you never understand why they are doing them, because they are not their mandate. They've created animals called the School of Government. I'm not against government working on developing a capable developmental state. I support that. But it does not mean you must take away mandates of other institutions of society for things that they can do better than you. I see the development of that school of government as undermining the role of universities in South Africa. It's important sometimes to speak the truth, so that the message, I like this thing, is recorded. So it can go for years. You see, as much as somewhere else it has been copied, there it is working, and we know why it is working. But here we're in a different environment. I can tell you one day that thing is going to be caught on corruption and caught on everything else and all that. It's me saying that, unfortunately, I've gone out of hand. Professor Asamani, you remind us on important things that we have forgotten. And we pretend that we understand. That more health workers are needed than currently available. You heard me earlier on, one of our political leaders in a public platform said we have got an oversupply of doctors. I mean today. That was said last week. You remind us there is a need to train more. There can be frustrations in terms of absorption in the market and all that, but the need remains there. But you also remind us that immigration is here to stay. We are part of the global village. There will be movements. Perhaps what we should be visiting, in the past, we looked at the human rights component of immigration. We went to an extent of developing ethical codes for recruitment. And those ethical codes these days are being breached left and right. Nobody is enforcing anything. Nobody is following up. Why are we doing these things? Private sector in South Africa continues to steal from the public sector without anybody holding them accountable. They have become good friends of government. They say we'll donate money and steal your people. So they donate 10 rand and steal R1 billion. You remind us again that the level of production where we are will not be enough to sustain the country in the future. There is a need to change course. When are we going to change course? We're busy writing documents. You heard Dr. Bayeni. He's my brother. We're busy writing documents. On one side, you are writing document. On the other, you are pushing them to the street. What are you writing the document for? So, in those words, I want to thank you for the input. I just wanted to touch on some points that I got from the message that, Chief, the task is big, but I believe you are equal to the task. You know, we'll support him, sir? Yes. So, I want to thank you for taking time to be with us today. I hope you have tasted our mngusho and mleqwa, and you'll come back. Ne? I want to say I want more time for some people. Come, we work together here. Hopefully, we'll explore modalities in order to achieve some of the things. So, in those few words, I want to thank everyone for being here in this great symposium. I'm pretty sure the university is happy. We are happy to be part of the national discourse, and the points discussed here will definitely be talked about out there, I'm pretty sure. I said I must take the opportunity to be provocative a little bit so that in the social media they can write about me as well. You know, so without wasting time, thanks program directors. You have managed to drive us. It was a great program and with your great direction. I'm pretty sure there's a lot that we'll do together on that. I want to endorse what Skumbuzo said. National government want access to data. Thank you.
Thank you very much, Dean. Let's give him a round of applause once more. We have reached the end of our program for the day, and we would like to also sincerely appreciate and thank you for being a good audience. You have made our job very easy, even when we had to adjust the height of the camera and the stage and whatever to accommodate us. I mean, we are not the same in terms of the height, but so you were a good audience. That's good. We appreciate and we thank you very much for that. And I think we have also heard that some of the calls are not to positions, are not to structures, but to us as the audience here. We are all government when we're seated here. So when they say government must, don't look at one side. Ask yourself, what is it that I can contribute? So that as a collective, we can see how we can go forward and make sure that we help each other. So I am also comfortable that my boss was here, so the partnerships with the universities, it should be a straightforward thing on my part. Safe to say that the country is hosting G20, and under the health